Hello and welcome to the Project iCare podcast. This is a recording for healthcare providers who want to learn more about improving care for patients with substance use issues and addictions. I'm your host, Dr. Casey Claiborne, a clinical psychologist and research scientist at the University of Texas Dell Medical School.
And my name is Sydney. I will help narrate this podcast by defining terms, explaining concepts, and citing statistics that are relevant to the topic.
Have you ever had a patient who struggled with quitting smoking? In this podcast, we will discuss some common challenges and approaches to caring for patients who smoke. We'll also discuss the rise in popularity and health effects of electronic cigarettes. Today, we are podcasting from the beautiful city of Providence, Rhode Island, with Dr. Patricia Cioe. Dr. Cioe is an assistant professor at the Center for Alcohol and Addiction Studies in the Department of Behavioral and Social Sciences of Brown University. Welcome, Dr. Cioe.
Thank you, Dr. Claiborne. It's a pleasure to be here.
Today, we're talking about patients who use tobacco and the impact of smoking on their health, with a special focus on people with HIV. So, can you discuss the health effects and related economic burden of cigarette smoking?
So, tobacco smoking is the leading cause of preventable disease and death in the United States. And this results in about 500,000 premature deaths and more than $300 billion in direct healthcare expenditures and productivity losses each year. It's been more than 50 years since the first Surgeon General's report on smoking and health, and cigarette smoking among U.S. adults has been reduced by half. But we still have a long way to go. In the general population currently, about 16% of adults in the United States smoke cigarettes. However, disparities in smoking prevalence persist, and among certain populations, the prevalence of smoking is much higher. Smoking cigarettes is very harmful to one's health. Combustion of tobacco produces carbon monoxide, commonly called CO, which is harmful to one's health. People who smoke have increased rates of cardiovascular disease. Tobacco also contains numerous toxicants, and several are carcinogenic, so smokers in general have a higher incidence of cancers. Smoking also is a significant cause of lung diseases, including emphysema and chronic obstructive pulmonary disease, or COPD. Cigarette smoking is a very significant issue in people living with HIV. As you know, the advances in antiretroviral therapy since the mid-90s have lended a longer, near-normal lifespan for people living with HIV.
So why is smoking so important to address in people living with HIV?
People with HIV have a much higher prevalence of cigarette smoking, with most studies estimating the prevalence at about 40 to 60% among this population. This is very concerning, especially when we consider the detrimental health effects of cigarette smoking.
Can you discuss some of the increased risks for smoking among people living with HIV?
People with HIV have an increased incidence of heart and lung disease, including myocardial infarction, pulmonary diseases and infections, and smoking and non-smoking related cancers.
According to the Centers for Disease Control and Prevention, smoking causes stroke and coronary heart disease, which are among the leading causes of death in the United States.
In fact, one study that was published in 2013 by Helleberg and colleagues reported that people with HIV lose more years to smoking than to HIV infection itself. This is very concerning for this population.
So why do you think that there's a higher prevalence among people living with HIV than the general population?
A higher prevalence of smoking?
Yeah.
So I think that one of the other reasons that people with HIV may have higher rates of smoking is also related to the ongoing stigma, both internalized and externalized stigma that exists in people with HIV. There's a significant degree of loneliness and social isolation. And I think finally these are some of the factors that also contribute to a higher rate of smoking in this population.
So what are evidence-based methods to help patients who want to quit smoking actually stop smoking?
Evidence-based medicine integrates clinical experience and patient values with the best available research information. It is a movement which aims to increase the use of high-quality clinical research in clinical decision-making.
So there are very well-established population-based and individual interventions to lower smoking prevalence. So some of the population-based interventions that have been instituted include tobacco price increases through taxation, which have reduced smoking nationwide.
According to the U.S. Department of Health and Human Services, in a 2012 report by the Surgeon General, a 10% increase in the price of cigarettes has been estimated to reduce overall cigarette consumption by 3 to 5%.
There are also in every state comprehensive smoke-free laws which impact where people can smoke, and this lowers the smoking prevalence. Tobacco education, mass media campaigns, and state and federal measures to improve access to quitting assistance are critical to reduce cigarette smoking and smoking-related disease and death among U.S. adults. The Affordable Care Act has had a significant impact because this increased the number of Americans with health insurance and improved smoking cessation medication coverage nationwide. The ACA requires most private insurers to cover smoking cessation medications. Finally, most, if not all states, have Department of Health supported quit lines that provide smoking cessation counseling and often smoking cessation medications as well. On an individual level, we have 7 FDA-approved medications for smoking cessation. 5 include nicotine replacement therapy, and these include nicotine gum, nicotine patches, nasal spray, nicotine lozenge, and nicotine inhaler. We have 2 oral medications that are available through prescription, and these include varenicline, known as Chantix, and bupropion, known as Zyban. We know that smoking cessation rates improve significantly with the use of either nicotine replacement therapy or oral medications or a combination of both, and these approximately double or triple the likelihood of a person quitting compared with placebos in clinical trials. Smoking cessation counseling is an adjunct therapy to medication. It focuses on the behavioral and psychological aspects of smoking, and I would refer clinicians to the published clinical practice guideline. The lead author is Michael Fiore. The title of this publication is Treating Tobacco Use and Dependence, a 2008 update. It's a very thorough review of all of the evidence-based strategies for smoking cessation.
So, given all the tools for smoking cessation, how does this affect the outcome of smoking cessation rates among people living with HIV?
What is very concerning is that, to date, smoking cessation studies in people with HIV have demonstrated disappointing outcomes. They have low quit rates, poor adherence generally to pharmacologic therapy, and a lack of sustained abstinence.
I'm interested in learning more about these studies. We will continue discussing recent and current studies conducted with people living with HIV and smoking cessation later in this podcast. What about e-cigarettes or electronic cigarettes? Where do they fit in?
So that's an interesting question, because although the majority of HIV-infected smokers report a strong desire to quit when asked, few actually do quit.
According to the CDC, in 2015, 7 out of every 10 U.S. adult cigarette smokers reported that they wanted to quit completely. Tobacco and nicotine dependence is the primary reason that quitting is so difficult for smokers. More people in the U.S. are addicted to nicotine than any other drug. Research also indicated that nicotine may be as addictive as heroin, cocaine, or alcohol.
Also, a significant proportion of them don't endorse total abstinence as a smoking treatment goal. About half actually choose a treatment goal that includes some form of occasional or controlled tobacco use. Consequently, smokers with HIV may be more likely to perceive reduced cigarette use or use of an alternative nicotine product, such as an electronic cigarette, as an acceptable alternative to ongoing cigarette use or smoking cessation. Electronic cigarettes are an interesting alternative to smoking combustible tobacco. They may represent a form of harm reduction for smokers who cannot or will not quit.
According to the Pediatrics Child Health Journal, harm reduction is a public health strategy directed toward individuals or groups that aims to reduce the harm associated with certain behaviors. When applied to substance abuse, harm reduction accepts that a continuing level of drug use is inevitable. Therefore, the goal is to reduce harm and adverse consequences. It emphasizes the measurement of health, social, and economic outcomes, as opposed to the measurement of drug consumption.
Does this mean that e-cigarettes are less harmful to one's health compared to traditional cigarettes?
While they are not entirely benign in effect, Studies to date have supported that they are less harmful than continued combustible tobacco smoking. Electronic cigarettes, unlike combustible cigarettes, do not produce carbon monoxide, and therefore smokers who completely switch over to e-cigarettes experience a dramatic reduction in their CO levels. Electronic cigarettes also contain many fewer harmful constituents compared to a combustible cigarette and may be less likely to contribute to smoking-related cancers. Some studies report that e-cigs aid in smoking reduction, temporary abstinence, and reduced craving. Many smokers reduce their combustible cigarette smoking when using electronic cigarettes, and this may lead to eventual smoking cessation. The long-term effects of e-cigs are unknown. However, a Cochrane review reported that serious adverse events related to short-term e-cig use were rare. It's thought that over the long term, switching from combustible cigarettes to electronic cigarettes greatly reduces harm to users and those around them. Some have suggested that based on current knowledge, it may be feasible for healthcare providers to advise smokers who are unable or unwilling to quit smoking to switch to electronic cigarettes as a less harmful alternative to smoking and a possible route to cessation.
That's a lot of great information about e-cigarettes and their role in harm reduction and smoking cessation. Thank you so much for taking the time to be here with us and sharing your expertise.
Thank you so much for inviting me.
This has been a Project iCare podcast with Dr. Casey Claiborne and special guest Dr. Patricia Cioe. If you liked our show and would like to know more, check out our website at sites.utexas.edu/Health Innovation Lab or find us on Facebook at UT Health Innovation Lab. Visit our website to find out more about Dr. Cioe and other resources discussed in this podcast series. All the information will be linked in the description below. Stay tuned to hear Dr. Cioe discuss her current research projects. Thanks for listening. So I'm curious as to how you became interested in smoking cessation and HIV and how this became a line of research for you.
Well, that's probably a product of my many years of practice. So I've been an HIV provider since 2001, working full-time clinically until 2012 when I came here to Brown. And in the clinical setting, I was observing that many patients were smokers, many were having cardiac events, and having cancers related to smoking cigarettes. I became initially interested in cardiovascular risk reduction, and I still do have some projects that focus on improving physical activity and heart-healthy behaviors. But I've taken a specific focus of smoking cessation because it's such a significant issue to maintaining the health or improving the health of this population of patients.
Absolutely. Earlier, you mentioned some recent studies for smoking cessation among people living with HIV that were conducted with methodological and other limitations. Can you discuss some of these studies and their outcomes?
The studies that have been conducted have several methodological limitations, such as a lack of randomization or a lack of biochemical verification of abstinence. And often in these studies, there is little or no long-term follow-up. The authors of the report concluded that there's a need to improve the success of smoking cessation interventions for people with HIV by conducting well-designed, randomized controlled clinical trials, developing and testing more efficacious interventions, and testing interventions that have a broader reach.
In light of these other studies, can you share with us some recently published work with smoking cessation?
One of the literature reviews of smoking cessation studies in people with HIV that was published in 2016, the lead author is Ledgerwood, reviewed the efficacy of behavioral treatments, mHealth interventions, and treatments using medications. The authors concluded that there were very few clinical trials examining the efficacy of smoking cessation treatment for people with HIV.
So given your interesting work with smoking cessation with people living with HIV, can you talk about some of your recent projects?
A paper that we published earlier this year in AIDS Care examined, using qualitative interviews, barriers to smoking cessation in people with HIV. And we found that they face multiple barriers to quitting, some of which may be unique to them. Participants reported that they have difficulty quitting due to a high level of dependence. They have smoked heavily and for many years, and they have a low level of self-efficacy or self-confidence for quitting. Some have reported that they're surrounded by other smokers and have a lack of social support for quitting. These are factors that negatively impact smoking cessation success. Finally, participants reported that they use smoking as a means of managing their stress and anxiety. And they reported a low level of readiness to quit. Some even felt that they were ambivalent about quitting and really were not interested in quitting. We have a small study in which we're currently enrolling HIV-positive smokers into an open trial and asking them to replace their combustible cigarettes with an electronic cigarette that we are providing to them for an 8-week period. We're seeing them for weekly visits, refilling their e-liquid, and collecting behavioral and biological measures. A follow-up study, which will likely begin in about 1 to 2 months, will be a randomized trial in which we'll enroll 72 participants, and they will be randomized to an e-cig switch condition or continue smoking their usual brand. Our primary aim in this larger study is to examine the effect of e-cig distribution on both e-cig and combustible cigarette use in people with HIV. We're hypothesizing that participants randomized to the e-cig condition will have greater e-cig use and a greater reduction in combustible cigarettes over the 6-week e-cig distribution period compared with those in the control arm. We plan to examine the effects of e-cig distribution also on smoking-related cardiac and pulmonary health measures. We hypothesize that biomarkers of cardiorespiratory health, measures of pulmonary function, and tobacco toxicant exposure will be improved in the e-cig group compared with the control group. We're also going to look at the effect of e-cig distribution on craving, nicotine withdrawal symptoms, intention to quit smoking, self-efficacy for quitting, and cessation attempts. And we hypothesize that those in the e-cig condition will have higher intention to quit, higher self-efficacy, and make more quit attempts than those in the control condition. We're excited about this study because it's the first study to examine the effect of e-cig distribution on smoking behaviors, inflammation, and respiratory function in people living with HIV.
Dr. Cioe, you're doing incredible work with your team at Brown University, and I'm really excited to hear the findings once these studies are completed.